Okay, we've all been there, right? You've got an elderly patient with a bunch of rib fractures. They're struggling to breathe, and that usual cocktail of painkillers, it just isn't touching the sides. Well, a pretty interesting paper in the journal Injury is looking at a promising new technique that could seriously change our approach. So let's take a closer look. An older patient with multiple rib fractures. It's such a common and honestly a really challenging presentation in the ED. The pain is often just awful, really difficult to manage with our standard analgesia, and that can lead to this whole cascade of nasty complications. And the stakes are incredibly high here. Rib fractures are a huge cause of morbidity and mortality, especially in our older patients. When you can't control the pain, you get into this vicious cycle. They don't breathe deeply, hypoventilation, which leads to pneumonia, and then maybe even respiratory failure. And the very opioids we rely on, they come with their own set of serious risks, like respiratory depression and delirium. You really feel like you're caught between a rock and a hard place. So this recent paper from the Mayo Clinic looks at a potential game changer, the erector spinae plane block, or ESPB. The big question is, can this technique be done safely and effectively by emergency doctors like us? So what exactly is an ESP block? Well, basically, it's an ultrasound-guided injection of local anesthesia. You put it into a specific fascial plane in the back, and the magic is that the anesthetic then spreads out and blocks the spinal nerve roots at multiple levels. You get this really wide area of pain relief from just a single injection. It's a pretty elegant solution to a really tough problem. Now, you might be thinking about other blocks, like the traditional paravertebral block, but the ESPB has some pretty clear advantages over that. For one, it's technically easier to do. The target is more superficial, and you've got this lovely bony backstop, the transverse process, that really reduces the risk of hitting the lung. So it's just a safer and more practical option for a busy emergency department. All right, let's get into the study itself. The whole point was to see if the ESPB could be performed safely and effectively by non-specialists. We're talking emergency and surgery residents here. So this was a prospective observational study. They took 19 patients who came in with traumatic rib fractures. And here's the key part. The blocks were performed by junior residents, under supervision, of course. The main goal was just to assess, is this feasible and does it actually work? And who were the patients? Well, they were pretty much exactly who you'd expect. A median age of 70, with an average of about 4 or 5 fractures per person. This is exactly that high-risk population that we worry about the most. Okay, now for the good stuff, the results. The study was really focused on 3 key outcomes: what happened to their pain, their opioid use, and their breathing. And the results were frankly impressive. The median pain score, it dropped from a 7 out of 10 down to a 4, and that was just within 1 hour of getting the block. That's a huge, clinically significant improvement that you'd absolutely notice at the bedside. The ESPB also had a massive opioid-sparing effect. We're talking a 41% reduction in their daily opioid use. For elderly patients who are so susceptible to the side effects of opioids, that is a major, major benefit. But this might be the most impressive finding of all, the improvement in their breathing. They measured the maximum inspiratory pressure, which is basically a gauge of respiratory muscle strength, and it more than doubled within 24 hours of the block. I mean, that's clear objective proof that the ESB can help prevent those nasty respiratory complications we talked about. So the results look great, right? But what does this all mean for us, working in UK emergency departments? Let's take a bit of a critical look at the evidence and the practical side of things. The study's main conclusion is pretty straightforward. The ESBB can be done safely and effectively by non-specialists in the ED. I mean, they had a 100% success rate with no complications in this group. As a proof of concept, that's pretty powerful stuff. But is this one study enough to completely change our practice tomorrow? It's always a good idea to think about the limitations. And yeah, the study does have it's a small sample size, only 19 patients, and there wasn't a control group, so we can't be 100% sure the improvements weren't just due to time or other painkillers kicking in. So while the results are really promising, we definitely need to see them backed up in a bigger randomized controlled trial. Patient selection is also absolutely key here. It seems like the ESPB is going to be most effective in patients with isolated chest trauma who are in a lot of pain and showing signs of respiratory compromise. Is probably going to be less helpful for, say, a major multi-trauma patient with lots of other injuries or someone who isn't really in that much pain to begin with. So what's the final word? The bottom line, the ESP block is a really, really promising new technique for managing the pain of rib fractures. This study suggests it's safe, it's effective, and, crucially, it can be performed by non-specialists like us. Now, do we need more research? Yes, for sure. But this study gives us a really strong reason to start looking into this, to start training, and to consider how we could bring the ESPB into our own departments. For our patients, this really could be a total game changer.